Okay, it's 5 o'clock. I'd like to welcome everybody to the June regular meeting of the Indian River County Hospital District. I'd like to welcome everybody in the audience and anybody who's watching us on TV. Okay, so we will go ahead and get started. We're very pleased today to welcome Rabbi Michael Bernholtz here to give us the invocation. Rabbi?
Thank you very much for welcoming me, for the invitation to be able to come and to speak before the hospital district. I'm going back and forth between two different versions of the same story. One is about Simchat Torah, which is the story, the holiday where we celebrate the end of the reading of the book of Deuteronomy, and then we have a big celebration and party, and then you start the reading of Genesis in one night. But there's another way you can tell the story, which is the version of the Christmas ham. And I was trying to decide, Rabbi, Christmas ham story. So which would you prefer, the Christmas ham version, or do you want the Simchat Torah story version? You want the Christmas ham story. You want to see if I can do this, don't you? So the story is one, and you might have heard it. It's such an incredible, simple story, and yet it's so powerful. A young girl is there with her mom, and they are preparing the Christmas ham. And they take out the special pan that they use, and they have the herbs and the spices that they use, and the mother very carefully, before they set it in the pan, cuts off the ends of the ham. And the daughter says, "Why are we doing that?" She's like, "I have no idea. That's what Mom always told me to do." You want to know, what do? Call Grandma. So they get on the phone, they call Grandma, and they explain all of the different stuff. She says, "Exactly what I do." And then you get to the part and you cut off the ends. Of course, that's what everybody does for their Christmas ham. She says, "Why do we do that?" The little girl, she's curious. She says, "Why do we do that?" "I don't know. I learned it from my mom. Go call your great-grandmother." So they all pile in. Eventually they decide, and why FaceTime when you can visit? And so they pile into the car, and they go to the assisted living facility, and they go into the assisted living facility, and they're sitting down with Grandma, and they explain all of the steps, and they say, "And you cut off the ends of the ham, and then you put it in the pan, and we're wondering why you do that." She's like, "Well, of course you have to cut off the ends of the ham, because otherwise it doesn't fit into the oven." The Simchat Torah version is that they're dancing and they're going from one synagogue to the next, and they always, at a certain point in the dance step of the song, they have to squat. And a guy who's been to all these different places has never seen, when you're dancing with the giant Torah scrolls, anybody ever squat. And they ask questions, they go generation to generation. They find out in the old building that when they had to dance, they had to open up to different parts of the building, and there was a place where there was a door that was low, and everybody had to squat. It's the same story, and yet it's so beautiful and so powerful. How often are we going through the process of doing things? Here you're going to be talking about our hospital district and about our community, healing in our community, and making choices and learning about different parts of our community, and how often we go through the motions and we don't always ask where we are learning these things from. We are not knowing necessarily where we inherited something that could have been for some crazy reason 20, 30, 40 years ago, or maybe it was perfectly reasonable 10 years ago, or we did it for one reason or we did it for another reason. And here we have this rich tradition of how this body has operated and functioned for all of these years, and here we have these times where we have to ask ourselves, is this the right time to ask with our curiosity, to wrestle with each other and discuss what worked in the past and what do we need for here in the present. And ultimately, as you see in this story, it's not just the answer that's beautiful, it's the fact that across the generations and across these different people, asking questions, talking together, listening to each other, they get to something that's the ultimate higher truth. And how can we, as a hospital district, as a community, talking about healing, how can we work together to find that way, to find the wisest and the best way to lead our community forward? From the Psalms, a very simple verse, Adonai oz li amo yitain, Adonai yivarech et amo v'shalom. God, give us the courage and the strength and the patience, talking with each other, sharing stories with each other, asking questions together, to make this a place of shalom, of wholeness, harmony, and peace. Amen?
Amen.
And thank you for the opportunity to address you.
Thank you so much. Michael?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Rabbi, I'd like to thank you for those words. They're very pertinent to exactly where we are right now and a good change coming, and to ask ourselves, what are we doing and what should we be doing? So it's a very good lesson for us to remember. And the ham, remember to cut the ham. We'll do that. I'm on it. And
Or buy a bigger
macaroni
pan.
dance, yes, we'll do that. Okay, we'll start with the consent agenda. I would like a motion for approval of the budget workshop minutes dated May 7th, May 14th, May 21st, May 25th, the chairman's meeting minutes dated May 16th, the regular monthly meeting minutes dated May 17th, and a June disbursement of, Mr. Jones?
$1,221,874.50.
So moved.
Second.
All in favor?
Aye.
Aye. Thank you very much. We obviously have had a lot of meetings in May relative to the budget, and we're going to have many more meetings. In fact, we decided yesterday that we were going to have a meeting on July 11th.
At 2 p.m.
At 2 o'clock in the afternoon, in order that is just going to be focused on the budget again. So we have a lot of time to discuss. So if you're interested in the 2018-19 budget, we will have that afternoon to discuss the whole budget, and you're all welcome to be there. That is all I have right now to report. District Council, Jennifer.
Thank you. As our chairwoman has indicated, we've been pretty busy this past month with the budget cycle and a lot of meetings associated with that. I've attended those meetings along with the trustees and participated in hearing the proposals, and look forward to the upcoming budget meeting where some decisions will be made by the board on behalf of our funded agencies. Also have participated in additional due diligence as it's continuing with the transactional process that is underway with regard to the partnership with the hospital and the Cleveland Clinic Foundation. And so between the budget cycle and this transactional matter, been pretty busy with that this past month. And have also been available for all of the trustees and continue to be available as needed for questions related to any of the district's matters, and certainly as it relates to the ongoing budget cycle funding and also the transactions we're working towards. Any questions? Okay,
Thank you.
thank you.
Financial statement review, Mr. Jones?
Well, as usual, the district remains in sound financial condition. Through May 31st, we had about $8.6 million in the bank, consisting of about $2.3 million for special operating reserves and about $6.2 million for the budgeted operating items. Budgeted expenses projected to be spent to current rate between now and fiscal year end total 5.8. So it sounds like we've got a little more money than we're going to need. However, it's important to note that IRMC is running at a rate of $1.2 million over the budgeted level for indigent care. This is mostly driven by increased volumes, as year-to-date indigent volumes are up 14.4%, including the 11.2% is inpatient care, which is generally more expensive than outpatient care. So while the district has discretion over reimbursing IRMC for these indigent expenses, we always have and expect to do so again. This may involve drawing down our reserves somewhat by the end of the fiscal year. So I just want you to keep in mind that the surge in IRMC's volumes as we go through the budgeting process. That concludes my report.
Thank you. Any questions? Okay, hearing none, our Executive Director report, Anne Marie Soriano.
Okay, I think I have covered most everything in my written report that is in front of you, so unless there's questions about that, I probably won't read through those. A couple of things that I did forget to mention actually was that I did meet one more time with the County Metropolitan Planning Organization, which came before us, I think, in April or so, and talked about an expansion or projected expansion of what we call Huma Crystal Boulevard, which is 11th Court, I think that's called, that comes past the emergency room and then more of the discussion this time went to extending that across 37th Street and connecting it to 41st Street. So that piece, I don't think Mr. Mattson and whomever else spoke to us really addressed, but that's more on their docket, so they're going to come back to you probably in July or so and talk a little bit more about that. The important piece of that is that it would connect where today the entrance to the Behavioral Health Center is. And so there's a relatively small road piece that road would take up and get close to the building, the actual building of the Behavioral Health Center. So I expressed, some of our concerns, what I feel like are concerns about that to them, and they're looking at right-of-ways and looking at maybe the ability to move that to the west a little bit so that we would get, there's, to me, I think a concern of traffic going through that close to that building and the population that resides in that building of the Behavioral Health Center. So I think they're going to look more at that and then come before you and talk to you further about that. I also had an opportunity to meet with Mrs. Davis and the Envision group that has taken over the ER. You're going to hear a little bit more about that tonight, but I did have the opportunity to meet with them and talk with them about the rates and how they are charging for physician services, which is something we don't cover in the emergency room to the indigent population. So they're going to work through a process for that, and some of that they might touch on tonight. I'm not sure if that's included in the presentation, but just so you know that that's on our radar and we're talking through that. Other than that, we talked a minute yesterday about, on Wednesday, about our strategic planning process, and that we would need to revisit that or should revisit that. I'm not sure if you would prefer that I get in touch with Mr. Felix, who helped us through that the last time. If you have other ideas of other facilitators that you might want me to reach out to see if they have interest in coming and facilitating that, or if it, I think we should use an outside facilitator to update that strategic plan and help us look at the future, at least for a 3 to 5 year period. So if you have ideas of others that we could use for that process, I'm happy to engage them.
Yeah, I would hope that we could start in the fall, September timeframe to really
So I would need
have
to,
those
get
discussions.
in
So
touch
you would
with
need to get
some
in touch
people
with
to
somebody fairly soon. So I
get
don't
into
know,
their
does
schedule.
anybody have ideas of other people? Are you supportive of Michael coming back?
I think Michael did a great job. He knows
I thought
what's
he did
going
too.
on, and I
And he
think
knows
to
our
continue,
plan.
there's nothing, unless he's not available.
Right. That was my first impression, but I thought I would
Yeah.
see if everybody's comfortable with that. I
Otherwise,
would be happy
Somebody
to.
else would have to start at square one,
Right,
Yep.
right,
I'm okay.
which would be a little more involved.
which they all can do.
No, I said I'm okay with that.
Yeah. Okay, great. I'll put a call into him. That's all I have.
Okay. All right, Rick Van Lith is here to talk to us about the ER Navigator program. It's been a while.
How you doing? Well, thank you everyone for inviting me back to speak about the program. It has been a while. I'm going to go through this relatively rapidly, but the environment has changed, not just the hospital and the considerations we have with the Cleveland Clinic, but the provider environment, the flu. There's a lot of things going on. So as we go through this, there's impacts, and I'll try and note them. Okay, so why did we get into this? There was a community health needs assessment that was a cooperative around with multiple agencies that I'll get into. That one of the major initiatives, one of the, I believe, 9 out of the first ones, was reducing the inappropriate utilization of the ER, which puts the patient in a state where they can have a continuum of care. If I have diabetes, let's manage my diabetes with the same physician watching what I'm eating and managing me rather than going from event to event in the ER with no continuum of care. Now, the folks that have been involved with this from the beginning, the Department of Health, Treasure Coast, the whole family, the VNA, the senior resources, a lot of the folks are in the room. I got to thank them. We're like 23 meetings deep from concept to today. So Karen, thank you very much. The Department of Health, Julianne and Tony Brown have been there through almost all the meetings. Vicki and Sabrina Hooks and Katie Hall, as well as a cast of thousands, I should say. We've really been working together to solve this issue. As I said, change in leadership at those agencies, the VNA, not the Department of Health, but the whole family. So there's been a lot of moving parts with this, but we've stuck with it. This was the original slide. This is the baseline. If you look at our high acuity versus low acuity, that is the urgent care-like visits, 70% of that 10,000 visits was in a category of either Medicaid, district, or self-pay. So that was what we're going after. Obviously, there is a disproportionate share at the hospital. We set about assessing the environment. The environment meaning, are these facilities with appropriate primary care near or adjacent or accessible? We worked with the Senior Resource Center with Karen. We've got the Go Line bus. We had after hours. So we took care of the transportation. That was something that was considered by the navigators. The other thing we did was we came up with a navigator role, which turned into the ask from you all to present, to do that. And that role has morphed and evolved as the program has morphed and evolved. But it's always revolved around educating the public as to where they can get care, scheduling the event, making sure they get there, calling them to make sure they get there, and have the provider calling them to make sure they come. So the hours of operation have been 12 hours a day, 10 a.m. to 10 p.m. since inception. So we started the program in March, and we were able to do that because in the end of December, through the generosity of the district, you provided us with 2 years of funding for a navigator, and we wanted to try a experiment with Walmart gift cards that had worked in other environments. To date, we've had 8,196 patient interactions with navigators and 1,519 actual appointments scheduled. Kind of who were we talking to when the navigators were talking? Half the time they were Medicaid patients, 23% of the time they were self-pay, 9% they were district, which is pretty consistent with the proportion we've seen. And HIS is they're going to land in either a self-pay bucket or a Medicaid bucket or a district bucket. They're in process of working the issue. So that's the 8,000 navigator interactions we had. And keep in mind, not every patient wanted to be interacted with. Referrals, 75% went to Treasure Coast. The health department, 201, 15%, and whole family, 11%. That's where, if they said they wanted to be referred somewhere, that's where we ended up referring those patients to. Now, this is the first 2 years, fiscal years. We're October to the end of September. We started the navigator in the middle of the red in March. That's when we had the navigators on board and started the program. And we were having marginal success, moving the needle, which was, I still remember that, Alan. So I was moving the needle, so we had success with that. And here's the kind of what we were looking at. These were the top complaints or reasons for care we had. Pain was always number one, flu was up there, women's health, falls, dizziness, dental, and on down the line. If we recall, we came back and we talked to you about women's health, and we found, somewhat surprisingly, that women were coming in to the ER pregnant, and there was a gap in the handoffs between departments, divisions. We brought in Healthy Start. Some of you on the Partners Collaborative were involved with that. That appears to be much better. If you look on the left-hand side, it's 6 months worth of data with 9 months worth of data. after we actually made those changes last fall, it appears that that's better and those handoffs are better. And it's because we had people working together to solve it. The other issue was dental. There really was not a, you don't go to get your dental issues resolved in an ER. You might get a pain pill or an antibiotic, but there wasn't really a good idea that, hey, this dental resource is out there. And both Treasure Coast as well as the Department of Health had resources, and we've made that information readily available in the ER, and our navigators utilize that, and it looks like we've had some impact with that. The thing we didn't have impact was with the flu. So you guys, you've seen different versions of this. We really had a flu spike that we haven't seen around this part of the country in quite some time. Hopefully it doesn't happen again. And this is all payers. If you go back here, the flu-like symptoms, it not only the indigent, it hit all of us, right? And all of us ended up in the ER for that. Now I'm going to that same graph. Now what happened? The flu bug hit us with that big spike. And you can see that beginning in November. There was a decrease in capacity at the Department of Health somewhat. And we continued upward. Now this is low acuity indigent patients. And the flu bug, if you just look at the numbers, the flu bug is really the biggest spike here, and that's what caused that. Now, so the major issues at this point for the program. Flu outbreak, hopefully it doesn't happen again. That did cause a big jump in our low acuity patients. The pregnant patients, we believe we made a real difference with them with the handoffs. We need to keep our eye on the ball because people change in the county. There's not an IT system that's across our county. It's people with phone numbers, and we all communicate with each other. Dental services is the same way. Making sure we have PCP provider access for patients, the indigent patients, District, Medicaid, and others. Treasure Coast currently has excess capacity to the point where we have blanks or open areas where we're scheduling in those areas, and we hope we can continue with that. Big issue is frequent utilizers. So the more we looked at this, the more we realized that a small number of people really drive this. One of the big issues is they don't have much in common. Many different things make you a frequent utilizer. So last 20 months, which is from October of 2016 through the end of May, 31 individuals, 900 visits. So why did they come to the ER? I pulled some samples to show you the difference. This person, if you look down at the bottom, 38 times. And if you look at why this person came, it'd be the prototypical of what you think. Alcohol intoxication, falling, those types of things. Flip side of this, here's a person that came 36 times. Chest pain. This person obviously has a cardiac problem. The other issue, and I won't torture you with too much of this, but here's a person with headache, epigastric, back pain. And the last one, this person obviously has a GI issue and a urinary tract infection. They're a kind of across the board, a cross-section of individuals with multiple disease states and different social situations. And what we've concluded is we need to deal with the person, because what we've been doing is they come to the ER and they're in the wrong place, and then we help them go to the right place. Rather than wait for them to come to the ER after they crash and burn or have an issue, the tactic we're going to try to adopt is to really oversee and look at their social issues and try and assist them to not have to come to the ER because they're well, because they're seeing their primary care doctor. And the classic chronic disease is hypertension and all the diseases, downstream diseases that occur with that, and diabetes. If you think about that, if you don't take care of yourself, you end up in the ER with a diabetic foot. You end up with hypertension. Hypertension is kidney diseases, visual diseases. I don't need to tell you. So That's, I think, the next step in the evolution of a navigator role. It's more of a proactive thing rather than a reactive when they come in. And trying to figure that out, we're going to do that with area providers as to the who does what. But I think that's really going to be the key to solving those few patients that drive excess inappropriate utilization of resources. That's it.
Question?
One question. The frequent people that kept on going back to ER, obviously one seemed to have an illness that
Sure.
preempted that. But all those people did not have a primary care physician somewhere that they could call and leave a message?
I would vent, and I don't have it in front of me, Anne Marie, but I would bet that the vast majority did have a primary care doctor. If they're Medicaid, they all have one assigned, and they chose not to go there.
Is it easy for them to have access to that Medicaid doctor or wherever? I mean, it's easy to go into the ER
Sure.
and to seek and get treatment.
Right, and that's the
But
issue we're
That is
dealing
the
with.
issue.
We're
So,
open 24/7.
because we all know that sometimes you can have what you consider an emergency, sit at home, make the phone call, somebody is on call, but somebody doesn't respond. You know how
Right.
and that's
Right.
anxious.
And I believe,
Anxiety producing.
I believe we're going to get at that issue by being patient-centric. We're going to be talking to them before they have the issue.
Okay, well, good. You've got a strategic plan for that all worked up?
Not quite yet.
But you see the ability to do that based on data that you're now gathering on these repeat
Right.
users in particular.
And I've talked to you, there's been a few surprises in here that we didn't expect. But it really, I think the patient-centric approach is really the right approach to resolving this issue. And we've been navigating events, not the individual across time between events.
So how receptive are these patients to that? Because
We're not there yet.
yeah, I mean, I just wonder if, if I'm coming 38 times or something, there's a comfort level I obviously have with coming
Right.
and getting that attention and getting that care there. And I would think some of these, there's underlying, I mean,
And each
could be
individual's
underlying
gonna
health
be
issues
each
for
individual.
sure.
Right. It might be
issue with their physician.
might be an access issue, it might not. Each individual, I believe, is going to have its own separate set of circumstances. I've got navigators in the audience.
But can you, I mean, with HIPAA laws and all that, can you talk to people that have in multiple times and really say,
We can share
we're trying
information.
to
It
help
depends on
you?
who's doing the conversation, though, too.
Okay. Yeah.
Any other?
Questions?
Yeah, just a technical item, but I'd just like to understand it. You mentioned something about the Department of Health had some reduction of services in December of 2017.
Right.
But I wasn't aware of them until the 1st of February 2018. That's a couple months difference, but that makes a difference in terms of the way I analyze these ER charts.
Sure.
What's the distinction there?
So there was, and I don't remember the exact date, but there was a point in time where we're proactively scheduling in open slots, and those slots weren't available at that point.
Is that for primary care?
Right, right.
Okay.
Okay, thank you.
Thank you. Great
Thanks,
job.
Rick, for what you're doing.
Thank you. To continue the discussion,
Round two.
round two. Thank you.
So I really appreciate the opportunity to come and speak and give you an update on where we are from the emergency department. We've spent a lot of time, a tremendous amount of time. It's been one of the #1 focuses at the hospital. And to let you know, we have made tremendous progress. We have reduced the time it takes for a patient, whether they're admitted or whether they're in and then discharged from the ED. We've reduced it about an hour and a half, almost 2 hours for those visits. And it's just following processes, putting processes in place, and making sure that everyone is accountable for what goes on. But as we continue to look at it, what we realized is that there's another problem that we haven't dealt with, and just as Rick was talking about, his is the great presentation. It's looking at those patients who come to the ED and why they come. And so what we realized, as you saw from the first slide, 70% of those patients who are medically indigent have lower acuity visits. And it can be a host of reasons. It's convenience, it's one-stop shop, it's a primary reason, I think probably plays a large part into it, is that if they go to primary care facilities, there is a financial payment that they make. And I think that it's probably pretty common that if they come to the emergency department, that has not been a factor. So I think there's a whole host of reasons. Probably it is convenience, one-stop shop, it's financial, it's a whole host of issues. But what we do know is that it's making a huge impact in our visits. And it makes it very difficult to take care of those patients who truly have emergencies, because we're having to weed through those that are non-emergent, the 58 visits by one individual, 36 by another. So what we are looking and what's happening in healthcare today, and it's not just in the medically indigent population, but it's across commercial payers as well, in trying to control the use of the emergency department for non-emergency issues. Many of the payers, Anthem being one of them, which is a Blue Cross Blue Shield plan, they are now saying that if it is not an emergent, and that's one of those 5 codes, and if it's coded as being a non-emergent visit, they're not paying for any part of it. They'll deny the entire claim. There are others that are making the patients having, with commercial insurance, pay a great deal more. So we're seeing it, it's a trend across the entire country, and so that was one of the areas that we looked at. But what we wanted to make sure that we were very comfortable in how we react from the emergency department is that we will take care of anyone who comes in. It goes back to the issue, though, that the rabbi spoke of, is the PAN. It's easier to come to the emergency department than it is to establish care in another location. So what we decided is to go the next step as we look at the flow issues and to determine what is causing the next step of the issue, and it's that volume. So as we looked, we decided that we needed to look at how we operate the ED. And as I told you before, we changed the process. So when anyone walks into the emergency room, the first person they see is a clinical person who assesses what their chief complaint is. They are immediately triaged. They see a physician right then who determines whether they're in an urgent situation or not. If it's a medical emergency, they go straight to the back. They don't stop. If it's not a medical emergency, but they still will go through a medical screening, and the screening process is always done by a physician. That's in our bylaws of the hospital. So it's, there's always that question, well, who determines whether it's an emergent issue or not? Our bylaws mandate that it is a physician who does that medical screening and makes the determination as to whether it's urgent or not. So now we have 2 subsets of patients, those that are emergent that we take care of straight to the back and they receive care immediately. And then we have this other subset of patients, and it's commercial and it's medically indigent. There's, it's the whole mix. So what we're looking at doing, and we talk about EMTALA, and that's one of the first things, is making sure that everything that we do is absolutely consistent with EMTALA. So the EMTALA rule, let me just see if I can advance this since I didn't have instructions, and I was the only female in the house, so they never let me play with the remote control, so I may have to have a little bit of help here. The first, it's the one after Rick's, please. Where he said, thanks, keep going, Rick's slides at the very end, please. Yeah, the last one, or the last slide. It's after thank you. There you go. Go up, 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 higher, higher. One more. One more. There we go. There's the EMTALA. Sorry. So the EMTALA rule, it's very lengthy, but let me just tell you what it says. And it says that when a patient presents not only to the emergency department, but within a hospital campus, we are obligated by law to make sure that we have screened them, and the screening individual has to follow our bylaws, and our bylaws say it's a physician. And what we're assessing is life or limb. That's the simple interpretation of it, is their life in jeopardy based on what their issue is when they present, or is there a risk of limb, loss of arm, loss of leg, something that is that emergent? And that is the guidelines, and that's what we follow. And we are adamant, we will always follow those guidelines. But then the next piece of it is once you've determined that it is not an emergent issue, that's where we're dealing with today. And so what it says is that the hospital has no obligation past that point. If it's no longer an emergent situation, there is no obligation for care. We can take care of them, we can, however we want to handle that group of patients, we can, but that's the federal guidelines, just so that everyone knows what we're dealing with. So what we have looked at from the organization is how do we deal with that 70% of the patients who visit the ED for non-emergent issues. And it goes back to the financial issues, and our volumes have gone up, our volumes have gone up in the emergency room, your charges have gone up. Again, it's the non-emergent patient. So what we're doing, not only with every payer that we have, is determining how they want us to handle that group of patients and where they charge. So we're starting, the patients will come in, they'll be triaged, and they'll receive a medical screening. That's the next piece. If the patient is deemed to be non-emergent, then that's where we ask the question. The other payers, including Medicare, will allow us to charge a fee for that medical screening. So we bring them back out. We never ask financial. We have no clue when they come in for their medical screening. We have absolutely no idea what their financial class is. It's only after we deem that they are stable that we ask that question. So with every other payer, we are discussing what do we do after that medical screening? What do you want us to do with your patients as a payer? Many of them are asking that there's a charge implemented at that point, and we give the patient the option. If the patient wants to continue to receive care, the payers will say, it's on their nickel, we're not paying it because it's not emergent. And so there are others where the patients will say, I'm not going to pay, but we still have the charge because we've spent time and effort in screening and assessing those patients. So the next step is we ask the patient, what do they want to do? And so really the question comes back tonight is how the district would like for us to handle those patients, because as a payer, we're not sure how you want. We want to help. We want to work collaboratively with you in controlling the cost. But the most important portion for us is making sure that those patients get to the right place. As the example as Rick showed you, you had one patient that came in 58 times. 58 times, he should have been in a primary care facility, the one with chest pains. Should have been. I mean, his blood pressure was elevated. That shows you have chronic medical problems that are not being addressed. There are others. The second one was a paraplegic that had frequent urinary tract infections, other issues of pain. Again, she has a chronic issue and needs to be seen on a regular basis with a routine care. But as long as it's easy for them to come in, there's no financial component to their visits. You know, you tried giving gift cards, and that wasn't effective either. So we're looking for suggestions, recommendations, positions on how do we address those patients. How do we handle those that continue 58 visits, 36 visits. I think I counted today, there were 86 patients, separate patients, who had more than 6 visits to the emergency department in the last 14 months.
Indigent or in general?
No,
All indigent, 86.
Medical indigent patients. So that could be Medicaid, it could be district patients, it could be self.
Over 6 visits each?
Over 6 visits.
In what period of time again?
14 months.
14 months.
14 months, and these are not pediatric patients, and they weren't OB patients. These are patients that's just where they receive their primary care. So that's 83 patients, over 6 visits each patient in 14 months. So working collaboratively, you know, we're asking for help.
Do you have a recommendation?
Well, we have 3 options as we see the options. The first option is no change at all. Continue exactly what's happening now, you know, and the patients will continue.
Of those patients, the Medicaid and Medicare patients, are you charging them, or are you specifically talking about the indigent patients that the district covers? Like, is there a combination of those patients?
Medicaid actually does have They have a co-payment,
Okay,
a calculation under the CMS guidelines for the Medicaid patients. For hospital visits, they do have a portion that they pay, as well as they pay when they go to primary care. So every group has, with the exception of the self-pay, in that we do have a co-payment with that group as well, and we work it out based on
What would the
poverty
copay be
group.
for Medicaid?
The Medicaid is 3% up to, I think the bill is 500. George, you may want to correct me on that number, but I think the maximum is
A
$15
$3 copay?
that they have to pay for the visits. So if it's a Medicaid patient, $15 times 58 visits, it begins to be a sizable amount. You know, and it becomes a deterrent to go to a different place.
Because right now, there's nothing. You're coming in, it doesn't matter whether you have a problem, you don't have a problem.
That's
We
exactly.
had been discussing this among ourselves in the past about having a copay system.
Well, and that's the second option that we would like to consider, is especially for those patients who are not emergent. The emergent patient's a totally different category, I'm not talking about those. This is the group that 70% of their visits are non-emergent, is that there would be, in collaboration, we would collect a co-payment for those patients from the district that come in. And again, it's not meant to be a penalty, we're just trying to help steer them to the right place for care.
What happens when you have patients who disagree with you? They say, what do you mean it's not an emergency? You know, for a lot of people, you know, from their own mindset.
Perception,
You know, it's perception, it is an emergency. What do you know,
right.
how do you try to reconcile that? Because I'm sure there must be a number of patients who disagree with you vehemently on that.
Absolutely, and you know, what is an emergent to me is not an emergency to a medical physician who is screening me. You know, it may seem like it if I have a pain, you know, if it's a dental pain or whatever the issue is, but it truly is not life or limb, and that's the criteria that we have to use, is that if they're at risk for life or limb. And we're not talking about pregnant women, we're not talking about children, we're just talking about those who come in repetitively. You know, and what we don't know, I mean, if you looked at Rick's numbers, 1,400 of those patients came in with the chief complaint of pain. So as we all become focused on, you know, pain and treatment and seekers for treatment for pain, I have no idea what element of those, because it's always a different physician they see in the emergency room. So is that a behavior? I have no idea. I won't even touch that as an issue, but it's just easy to come to the emergency department because there's no deterrent. And so we're just asking for help as we continue to work on the emergency room flow issue. Part of it is offloading the volume, that's not the right place for their care.
What's your third option?
I think Tracy had a very good question, though. Are we just talking about qualified indigent patients, or is it including Medicaid patients as well? Because a lot of Medicaid patients do not have access to a physician for primary care in the community. And so they do go.
They are assigned. They just
they're
choose.
assigned, they're just choosing not to.
All I'm saying is, it's a whole, so I don't know whether the district is being asked to reimburse for.
No.
No,
talking about
just for indigent
patients.
is what she's talking about. She clarified that.
Yeah, we're only talking about district patient. Every other payer group has their own criteria. Medicaid has theirs.
I
Medicare has theirs.
understand that, but I just, you know, because there were a lot of, not all those statistics were just given to us by you know, on just indigent patients originally. So I just want to clarify all of that.
No, absolutely. We looked at the entire package of, and we classify that as medically indigent in that they do not have a commercial
Right.
payer. They're either Medicaid patients, district patients, or true self-pay patients.
Right.
But what we're looking at goes across the entire gamut of our patients. It is not just the medically indigent. It's the commercial payers too, because the commercial payers are saying, get them out of the emergency room. That is not the appropriate place for care. And so not only
Back
are
to
they...
that again. Can you repeat that? It takes me a few times. What are the commercial payers doing about this situation?
Many of, the commercial payers, they've increased their copayment. They all have copayments, and many of the commercial copayments are as much as $400, $500, $600 for a visit to the emergency department. But there are many of the payers now that you will see are now beginning to implement the processes. They're looking at the screen, and if it is a non-emergent patient, they're denying the entire claim. So you come in with flu-like symptoms, and you may walk away with a $1,600, $1,700 bill.
Okay,
Because-
thank you. That's what I thought you had said, but I wanted to
I have
verify that.
Never be.
a couple of things. One, I think one of the key things you said was, you're not trying to punish the patient, you're trying to get them the proper quality preventative care, which I think is key. And you're trying to change a behavior so that they get that quality care on a regular basis and not,
You know,
hit the
Tracy,
ER.
May I say that that's exactly why we started this whole committee 23 meetings ago or whatever it is. Because of that, it's not a punitive situation.
Right.
It is
Trying to get people to the right
trying to get people to the right care, and we do. We are very fortunate. Our community have continuum of care like that we can provide, like Treasure Coast Community Health, Health Department, Whole Families, everyone that we've listed and are partners of ours in this. So there are places to move them. It's changing habit, and how do you change habits?
You're absolutely on target, and the rabbi could not have had a better
And I
start
will
out
tell
for
you
this
that almost
presentation.
every hospital that you go to, they do
Or-
that.
yeah.
Yes, they do.
If you-
I guess my question would be, do we have the ability with our special act and with our lease contract with you, do we have the ability to make that decision? Can we
Yes,
legally make that decision?
yes.
You can charge them a copay, and you can
Yes.
refer them to another provider that's more appropriate.
That is doing primary care.
Part of
Health
the
department.
issue,
That's right.
one
Referring
one
them to-
additional item that we've realized with the navigators is that patients will come in, and again, it's the deterrent, because there's no copay or there's no financial component in the emergency department. The navigators will make appointments for primary care visits for these patients, and they don't show up.
That we heard.
And they'll be back in the
I think Vicki
emergency
said that.
department in a couple of days, because it just becomes a
I think
vicious
Vicki
cycle.
said she had that problem at TCCH. They don't show up for their.
They don't show up, that's correct. Because there's no incentive to show up. If they go there, there's a copayment. If they come back to the emergency department, there is not.
So if
You have not
if we,
finished your third
well,
option,
okay,
though.
go
Sorry,
to the
I want.
third option.
What was your third thought on this?
The third option is that you make the patient fully financially responsible for the visit, if it's a non-emergent visit. Obviously, that's a tough one, but that's what the commercial payers are doing.
so if we agree with a copay, do you have a proposal as to what that would be?
Well, we have a charge for the medical screening, and it's one that's being applied across for non-emergent patients, which is $250. But what we are doing, because of the negotiated rate, that would actually be reduced down to $105 total fee for that medical screening if they come and it's non-emergent side of it. We can work and negotiate between the hospital and the district what that rate should be, and then come up with a copayment component to it. It has to be, in our mind, at least equal to and greater than what it would be for them to go to a primary care facility for it to be effective. So I think it would take
That's right, to get that incentive to go to the right place.
that's correct.
Yeah, I agree with that point. That's why I was getting ready to ask you, but I think it's going to be hard for us to tell you exactly what the copay ought to be, at least until we know what all the other copays are.
If we look at just the medical screening and we apply the discount to the $250 that we're proposing, then that would bring it down to $105. And then we can come up with a percentage of that $105 that would be the financial side for the patient. And I think, again, as I said, it needs to be higher than what it is for primary care.
And we have to find out what is the highest amount that each of the primary care charge, because I know there's sliding scales and everything, so it would have to be likely higher than the highest point.
Well, let's answer the first question first, which is, do we as a district support the hospital in doing a copay? trying to figure out what that is, I think we could take offline. But I think the answer that you're looking for right now is, do we as a group support that, right?
Do you want that as a motion?
I think we should have a
Okay, I
motion.
And I
motion.
think we have discussed that off and on, so I don't think it's something that just came to us tonight.
No, it's
No,
not.
we've been
Absolutely. We've
yes,
had a
I-
lot of discussion on it. So
I would
that's a
like to
very good
verify.
point, Anne Marie, that this is not something that we
No,
are just
it just didn't come
randomly
up.
doing
It just
tonight.
didn't come up.
We have been
No, no,
talking
have been
about it.
discussing.
We're doing it in the.
So I will put that motion out, please, that we look at doing a copay, or charging a copay for non-emergent indigent at the hospital.
Yeah, I'll second that.
The hospital, not, yeah.
Okay, any other discussion?
Well, discussion of how much, but it's just,
let's
Any other
make it a
discussion?
reasonable one.
Okay,
You know,
No.
no.
you always. Yeah, you used to always.
It's not a
ask.
major motion,
It's
but
not a major
we can have public comment if you'd like, Madam Chair.
we can have public comment, sure. Sure.
Just so you know, if you ever have a vote, you are supposed to have public comment first.
I think it's a major vote, is how we've
Well,
always
I
handled.
just want to let you know, and I'll just ask the attorney first.
Would you please address who you are, sir?
Oh. My name is Val Zudans. I live in Vero Beach, Florida.
Thank you.
I just wanted to ask the hospital district attorney, does a special act allow copays for indigent patients at hospital district-owned facilities?
I can research the issue for you, but I believe the answer is yes. The district has the ability to set those fees.
Actually, Anne Marie Soriano and I did an analysis of various districts, and that's one of the things that people do in, say, the Sarasota district. They charge, I think it was Sarasota's, $10 a copay.
We're the only one that does.
Some of them charge 25, but the
All right.
question is, can we do it? And the answer is yes, and that's why what Anne Marie McChrystal was saying is we've been discussing this for some time.
Okay. It was my opinion when I read through the special act that you cannot charge indigent patients for these services at district-owned facilities. So I just would encourage you to look at that. And if you're not allowed, you're not allowed. I agree with the concept. I think it's a good idea. But
I'm telling you, we
I don't
looked
think
at
you're
it, and they
legally
already
allowed to
came
do
to that decision.
Just let you know. Thank you.
Thank you.
Dr. Sudans.
Okay, given that, any other discussion?
Do we need to look at it again just to make
And
sure?
it-
I think we can do the vote, and then we'll go back and verify.
Based on the.
Subject to
Verification.
verification of that,
Verification.
subject to verification. So, all in favor?
All right, can I just ask?
You may ask a question.
We're doing this at the hospital emergency room, and when we had the discussions, we had a broader discussion that went beyond the hospital emergency room, if I'm correct. That in all visits, that we should consider a copay. Because here, we're doing with the hospital, and some people may say, oh, that's not fair because, I'm a physician and here I am and I'm not getting, get a copay. And it may raise a question that way. But I think if we're gonna talk about copays, we have to be on a broader term, not limiting it to one facility.
Well, I look at it a little bit differently, so I'm glad we're having this discussion. The whole, I think, effort here is to try to get emergency room staff focused on emergency situations and not become an alternative primary care. And though everybody involved, the hospital, the district, the community, has really tried to manage this program for a long time, and it's resulting in slowing the emergency treatments, or at least backing up serious cases if they're not totally emergent. So this is a way to approach it. Personally, I think that we should look at this, but exactly what that fee ought to be, I have a little trouble with a $105 fee when Medicaid is $3.
Well, 105 is the discounted amount for just that medical screening exam. And so we can and plan to, if it's okay with the district, to negotiate what that portion would be for the patient. Again, our goal is to to give them the initiative to go someplace else for primary care. So
It shouldn't be punitive, though. We have.
I don't want it to be,
amount.
and that's not our goal at all. Our goal is
I know, I understand what
100.
your goal is, but, you know,
Right.
we're dealing with people where $10 is a lot of money.
You know, for those at that income level, any dollar will be enough to make
It's a
them
big,
reconsider
it's a large
where
amount,
they
so I
go.
think we have to be very cautious on what we're going to put in as a copay.
Absolutely, and that's why
Otherwise.
we need the
I
advice
think
and counsel.
we need to take that offline and understand what other places charge and what the primary care areas
Sure,
charge.
$10.
Discussion on that
And have some
specifically.
discussion
Yes.
specifically.
Correct.
Absolutely.
So can we go, Tracy?
Do you mind repeating the motion with the verification in it, just so that we can get it on the record?
Okay, the motion, as I understand it, is to make a motion to support the hospital in establishing a copay for emergency visits for indigent patients, for our indigent patients,
District-covered patients.
based on verifying the fact that the special act allows us to do that.
Thank you.
So, can we take a vote now? And let's do it, we'll go down.
There was a second, is that correct?
There was a
There was a
second,
second.
yes, Alan did, so, Tracy,
Yes.
Karen,
Yes.
Michael,
Yes.
Yes.
Anne Marie,
Yes.
and I vote yes.
Thank
So
you.
we'll do that, but on the condition that we'd like to make sure that we come back and everybody is comfortable with what a reasonable
Absolutely.
would be. So I would like you guys to make a proposal as to what that would be.
We will work together with that
Okay.
proposal, and then we will provide follow-up to see if this is effective in decreasing the number of visits for primary care.
Okay.
And I think we also committed to double-check the legal status of us doing this, right?
That's correct.
That's
Correct.
double
It's
to
in the motion.
verification.
Yeah.
Right.
Thank you.
Thank you, Karen.
Thank you.
Okay, any unfinished business?
George.
Oh, George, I'm sorry.
Also,
George wants to come
I'm
visit.
sorry, this is IRMC night. All right.
Good afternoon, everyone. How are you doing?
How are you?
Fantastic. Do you have the handout that was prepared?
This one, right?
So, to make it official, I'm presenting the second quarter, March ended 2018, of the results of Indian River Medical Center. What I prepared for you is the second quarter is the first column you're looking at, and year-to-date is the second column you look at, and the variance is the third column you look at. And I've broken it out between volumes, staffing, revenue, expenses, and income. So let's talk about the second quarter. Indian River Medical Center had income before depreciation of $7 million. It had budgeted $7.9 million, and last year it had $6.5 million. After depreciation, it had an excess of $3.4 million. Last year, the budget had that's the wrong number. It's always good for George to present that. Quick math says 3.3 million, and the last year was 2.9 million. What drove that is let's talk about the volumes up at the top. Inpatient admissions at 4,000 compared to a budget, I'm sorry, let's start again. Inpatient admissions of 4,086. The budget of 4,050, and actual last year of 4,037. Observation, we had admissions of observation of 1,942 compared to 1,900 in the budget, in 1,995 from last year. So total heads and beds admissions were 6,028, slightly more than budget of 5,950, and just about at the same area we were last year at the same time. Patient days ran higher, our length of stay is higher. We're seeing a larger acuity of patients running through the house. Our emergency room, I think we've talked about the emergency room quite a bit, quite successfully today, at $17,135, which is compared to budget of 16,200. So you see there is an increase of about 800 visits over the quarter. A lot of that is the volume that we're seeing, and a lot of that is the flu as well. Physician visits over our physician practice, when you look at these numbers, you have to realize that our ED physicians stopped billing out and are not our ED physicians as of February 1st. And there's about 12,000 visits that would typically be attributed to that. So you have to kind of keep that in mind when you look at the visits. But for the second quarter, we had almost 60,000 visits compared to 75 last year. FTEs, we're running at.
That's not an apples to apples, is what you're saying?
That's correct.
Okay.
The adjustment factor is about 12,000. FTEs at the hospital are running for the quarter running at 1,427. We had budgeted 1,380, and last year we had 1,362. I will say that for the second part of this year, we are spending more money on the patient care areas, and that's what you're seeing here. I think they're unbudgeted expenses, but they're very important expenses. I think over the last 3 or 4 months, we've determined that there are some gaps that needed to be filled in the nursing area and the patient care area. So you're going to be seeing that going forward. You see it in some of the results for this quarter, but you'll see it going forward throughout the year. Physician FTEs are about 330, and compared to 325 for the budget. Let's talk revenue. So you can see for the second quarter of this year, the hospital generated $61.4 million of net revenue compared to $62.2 in budget and $57.7 compared to last year. Now we've seen a slight increase in volume and a slight decrease in revenue, and what's happening is you're seeing a shift away from the commercial payers more towards the uninsured and indigent. So you're also seeing the indigent care volume increase, and that impacts our bottom line because we don't get paid quite as well. On the personnel cost side, we're running at about $40.8 million compared to $41.9, and again, included in that number is the emergency physician, so it is a little bit of an apples to oranges comparison. On the supply side, we're at $16.5 million compared to $16.8 or $16.9 for budget, so we're slightly under budget. We are over budget by $1 million. Over compared last year by $1 million. Most of that is related to oncology drugs, but we're also doing additional high-cost surgeries in the orthopedic and cardiac areas. Total expenses at IRMC came in at slightly under $70 million, where we budgeted $73 million, and last year we were about $70 million. So some of the supply savings from last year are offsetting some of the expenses that we're seeing on the labor side. That's quarter two. For year to date, I wanted to talk about the complete picture. Inpatient admissions at 7.8 is about 5% higher than what we had budgeted for, and about 6% higher than where we were last year. Total admissions are about 140 higher, 1.3% higher than budget, and 1.1% higher than last year. Patient days, I talked about length of stay, so they're, even though admissions are up about 1%, days are up about 8%. Emergency room visits, we're running 4.3% more than where we had budgeted, which is about the same number that we budgeted for, that we saw last year. Surgeries, we're running at 5.8% more than budget and 6.2% more than last year. So overall, you're seeing an increase on the house for inpatient, you're seeing an increase on the outpatient with emergency, and you're seeing an increase in surgeries as well. What that does on the revenue side comes in at $117,600,000, which is $2.4 million higher than budget and $13,400,000 higher than last year. A lot of that revenue has to do with volume, but also the commercial rate increase that we had. On the physician side, we're coming in at 27.3, and again, we have the distorter of the ED process, so we have less revenue than we thought. And so in total, we're very close to what we had budgeted for. We're within 0.5% in total at $150.1 million. And personnel costs come in at 80.5, which is 1% higher than what we budgeted for and 4% higher than last year. And when you bring it all down to the bottom line, Indian River Medical Center, the entire system, has $11.1 million of income before depreciation. And take out depreciation ends up with an excess of $4 million compared to $10 million of EBITDA and $3 million of bottom line for the budget. And last year we had $5.9 million of EBITDA and a loss of $1.1 million. So if I were to encapsulate all of this, we're seeing higher volumes. Some of that volume is being taken up by lower paying patients. We have seen significant improvement on our commercial rates, and we are spending more money on the labor side for patient care services. And thus endeth my report, and certainly take questions.
Any questions for George?
It is what it is.
It's a lot of info.
Yeah,
Thank you so much.
looks like much improvement. So
Thanks.
congratulations.
Well, thank you.
Keep the volume higher.
Must have a good CFO and CEO. And
Oh, yes, we have a great district, too.
Well, the good news is the pay increases that you had expected are flowing through, and you're not losing them, and that's positive, very positive. So thank you very much for that. Okay, now, any unfinished business? Any new business? And I think, John, we have John on other business, your request for funding?
Good evening, Madam Chair, Directors. For the record, John Romano, I'm the CEO of New Horizons. Do you guys have this handout?
Yes, we do.
Okay, great. I'll be a lot easier than the hospital. If you go to the first page where it says services provided, what we did was break this down simply, if you will, so you can take a look at what we've done in 6-month intervals. And as you can see, the numbers go up each and every interval, 6 months. We are at 25 for October 16th to March 17th, 65 April 17 to September 17. Now we're at 97. I'm not going to read all this to you. You can see the numbers, and they just escalate. The funding analysis is simple as well. The monthly average from last year to this year is almost, or actually it's more than doubled, from 2,028 to 4,832, almost $5,000. So the bottom line is we're showing a shortfall this year, this current fiscal year, of around $20,000. And as I mentioned to you briefly when we did our presentation for next year's budget, we're out of money for the hospital district indigent population. So we're asking for the remainder of this current fiscal year, another $20,000 to make us whole, if you will. And you'll see a little section here called contributing factors. The care card has really helped our clients anyway, and helped the agency, because they're coming in and they're pre-qualified. So that's a good thing for us, because in years past, as you know, we've left money on the table because we couldn't get these people qualified for one reason or another. So that care card has been good for New Horizons and, more importantly, our clients. We did add additional medical time to Indian River County. We hired a full-time nurse practitioner because basically of the workload. We have already used up all of our DCF, Department of Children and Families, indigent funding. We used that up probably at the end of April, beginning of May. So, and their fiscal year is different. It's July 1 through June 30th than the fiscal year that you guys are in. So that's kind of it in a nutshell. Questions?
I think your community partners have added a little bit more to your volume.
Yeah.
By identifying people that should be taken care of. I think that's probably what
For the
we-
mental health collaborative, the
Exactly,
connectivity
and I
center.
think that's what we had hoped would happen.
Yeah,
So
I
these
would
people
agree.
would receive treatment.
Right.
So, have you factored this into next year's budget?
Yes, ma'am,
Okay, good,
we did.
good.
We did.
My question would be for Alan, do we have it in our reserves to
Yeah, just
do
getting
that?
ready
Oh,
getting ready to
sorry.
answer that, in anticipation of that question. Yeah, we can find $20,000 to do that.
Right.
And personally, I think what you do is very important to the community. It's making
I
a
agree.
big difference. And so I would make a motion that we
I'll
fund
second
the
it.
$20,000 for the balance of the
Second.
year.
So move, did somebody move?
Yes.
I'll second.
I thought I did, but
You did, it's
There's a
been
lot of seconds
seconded.
going on.
Any other conversation? Okay, all in favor?
Aye.
I have a question for you. Do you feel that there, because of all the attention that there is, because of shootings and everything else, is there a heightened sensitivity to that might also be more people getting help?
Yes and no. Yes to the fact that there's heightened sensitivity. If you read about the suicides that have made the papers recently, the Parkland shooting, I mean, it goes on and on and on. In terms of revenue following those catastrophes, not so much. Not so much. The state of Florida, which makes up around 53% of my budget, it's hard to get what we call price level increases. What they'll do is they'll add services to counties or organizations that don't have a particular service. Quick example, in some counties, they don't have a community action team for kids. We do in our circuit 19, we have a community action team. But there's a bunch of counties, and I don't know them off the top of my head, that don't have them, so they will appropriate money for those types of projects. And, but it doesn't help the base. We still get the same amount of money for what we call the FACT team, which serves Indian River County as well. Since 1999, it's 2018, that's 19 years, we haven't had any increases. That's doing business with our friends at the state level.
So you're seeing more people because of the sensitivity, but you're not getting the revenue?
Correct. Bottom line, yes.
I think the stigma behind needing behavioral health has kind of, gone down as well. So people are more willing to accept some of your help, and that's probably driving the volume as well.
Well, I mean, the volume increases every year. If you just look at the numbers, I mean, in all 4 counties that we serve, you'll see them ticking up every year. And you won't see the level of funding ticking up, especially for indigents. You have to remember, Medicaid is managed care now. So, you still have to beg, borrow, and steal I shouldn't say steal. You have to beg and borrow to get what we need. And, they like to say no, when we put in our claims, because they're managed care and they're private for profit. So, enough said. We have to fight for every dime we get sometimes.
Well, we're happy to support you.
Well, we appreciate that.
Right.
Okay.
Thank you
And
so much.
Thank you for your
Thank you.
support.
Thank you.
thank you.
See, I was pretty easy. Have a good night.
Thank you, Wilson.
Any public comment?
I think this is correct, but just so you know, the Florida statutes, I think it's 2003, 382, Section 19, indigents. And this is specific to our hospital district. Each hospital and clinic established under this act shall be for the use and benefit of indigent sick who have resided in such county for not less than 1 year, next preceding application for admission for treatment. Such residents shall be admitted to such hospital and clinic and be entitled to medical care without charge, subject to the rules and regulations prescribed by said Board of Trustees. Such hospital and clinics shall care for and treat without charge only such patients who are found by such Board of Trustees to be indigent. But such board may collect from patients financially able such charges. Such Board of Trustees may from time to time establish. It goes on to talk about people outside the county, but anyway, I'm pretty sure that it's pretty plain on that, but you guys need to look into it.
Thanks for doing that research, Dr. Zudans.
Thank you. Any other public comment? Okay.
Actually, there's one thing I'd like to say, because I thought about it related to the other research we're going to do about the amount of copay if it's legal to do. And because there's another issue involved, and that is hours of available service. So when whoever is going to represent us to be involved with it, I think that should be on the table for the other providers, not just the hospital, because the hospital's 24/7 and everybody knows it.
Mm-hmm.
But the others are mostly 8 to 5, give or take. And that may be a factor that ought to be included, so as we decide how to take care of the indigents. I just wanted to get that out there.
I appreciate that.
Yeah,
That
thank
crossed
you.
my mind too, that.
Yeah.
But then I think, well, if I went,
Absolutely.
I would have a copay regardless of the hour too, so, all those things should be taken into account, so. Okay, any other comment, thoughts? All right, we are adjourned. Thank you. Have a good evening, everybody.